Good evening, Asmita. We'll start in 1 minute's time. 1 more minute, I'll start. Okay, Asmita, shall I start? Okay, good evening to all of you. I'll start with a short case first and then go to 2 long cases. Can you see my slide? Am I audible to you?
Yes, sir.
Okay. We'll start with a short case first. This is a story of a 30-year-old female. Her complaint started 2 weeks back as pain radiating along the right arm from shoulder downwards 2 weeks back. Along with this, she also noticed paresthesia of the right shoulder and numbness of her thumb and index finger. 2 days later, she noticed difficulty in doing activities with her right upper limb. The pain did not increase by coughing and sneezing. So this is a short history, 2 weeks duration, pain radiating along the right arm towards the fingers, along with paresthesia of the right shoulder and numbness of the thumb and index finger. 2 days later, she noticed difficulty in doing activities with the right upper limb. The pain did not increase by coughing and sneezing. So this is the video of the patient. This is my left side. Deltoid is normal. Right deltoid is weak. Then left biceps normal. Right biceps is weak. Triceps is normal bilaterally, normal on the left side, also normal on the right. That's normal. Then brachioradialis is weak on the right side, left is normal, right side is weak. Then the knee extension is normal, wrist extension is weak on the right side, normal on the left side. Finger extension is normal. Wrist extension was weak, finger extension is normal. Hand grip was normal power. Finger abductors were all normal. External rotators were weak on the right side, normal on the left side. Internal rotators were normal. Lower limb muscle power is normal. Reflexes right biceps is all absent. Left is normally elicited. Left supinator normal. Right supinator is almost absent. Triceps is normal on both sides. Finger flexors are not elicitable. Knee and ankle jacks is normally elicited. Plantaris flexor. Sensory system. The test sense is normal on the area where she is complaining of numbness. She is able to count correctly. ശരി. ഇനി ഈ കുത്തുള്ള മാത്രമേ പറയാവുള്ളൂ. ഇത് രണ്ടും ഒരേപോലെ അറിയാവോ? ഈക്വലി പ്രസന്റ്. ഇത് രണ്ടും middle finger also is equally present. Able to feel vibration bilaterally. Joint sensor also normal. Which finger also normal. So that's the story of the patient. Weakness of the following muscles were noticed on the right upper limb: right deltoid, right external rotatus, right biceps and brachioradialis, right finger extensors, wrist extensors. Finger extensors were normal, and other muscles were all normal. DTR, right biceps supinated decrease on the right upper limb. Triceps finger flexion normal. Sensory system, there was no sensory loss in the right thumb and index finger, where she complained of the numbness. So where is the localization?
So the localization is mainly related to the right upper limb.
Correct.
So it is likely due to the C5 and C6 roots, maybe motor root may be involved.
Correct. It's called sensory symptoms also in there. Yeah.
Yeah. So this is one area.
Yes. So it says C5, C6 radiculopathy. That's the first possibility you have to keep in mind. It's also come radiating pain.
But regarding the wrist extensors, there is some weakness of the wrist extensors.
Correct. That is also C6 root.
C6 root is predominantly C6 root for the wrist extensor.
Very good. Perfectly correct. So wrist extensor predominantly C6. Finger extensor is predominantly C7. What is it? Correct. So it all fits in with the C5, C6 radiculopathy. Okay. So any other thoughts from anyone else?
Sir, can it be upper and middle trunk, sir? Upper trunk and
that's also possible. Upper and middle trunk is also, because C5, C6 root and up. Why do you want to bring a middle trunk?
Because the wrist extension weakness.
But that is C6 only, no?
Yeah, 6 only. Yeah.
So that means that upper trunk also can explain that.
Yes.
So C6 root and upper trunk difficult to differentiate, except for the weakness of the rhomboids and serratus anterior. But when there is severe weakness, you can look for that. Mild weakness be difficult to differentiate.
So external rotators are involved, no?
Yes, weak.
Yeah.
Infraspinatus was weak. That also goes for C5, C6.
C6, 5, C5, C6. It goes in favor of C5, C6.
Right. Okay, now what do you want me to do?
One NCB will do, sir.
Okay. And before, in fact, she came
MRI,
with an
MRI was
MRI.
done.
Okay, MRI was done. This MRI got a C4, C5, and C5, C6 disc collapse. I will show that later on. This is the axial cut. That is a disc. I will show the screenshot later. Okay, this is our axial cut. This is a corresponding sagittal and axial. Bring in the red line from above downward. So the corresponding axial, that is a C4, C5. Then C5, C6, that's a C5, C6. You can see the disc there. So this is the C5, C6 level, which is shown here. There you can make out that disc on the right side. So this is a disc on the dorsolateral on the right side. This is what they have written: ventral cord compression with an abnormality, CV nose to the right, C4, C5, and C5, C6. Now, so what would you like to do in this patient?
Nerve connection.
Nerve connection. Okay, NCS was done. Okay, NCS was, this is NCS. Duration is only less than 2 weeks duration. right median normal, right ulnar normal expected, right radial normal, axillary normal, musculocutaneous normal, supraspinatus, infraspinatus normal. But remember, there's not a severe weakness, only mild weakness. So FA latency is normal. Sensory also normal. So what would you like to do?
EMG, sir.
Why EMG for? EMG is anyway, we know it's low motor paralysis. It's got a sensory symptom, the thumb and index.
Please
You
look
can
for
identify the group of
patch.
muscles.
Pardon? Other group of muscles are affected. Yeah, that can be done, but we know the distribution is exactly in the C5C6 route only.
Look for patch of the upper lateral arms.
Okay, right. See the next video of this patient. It's got a numbers of the upper lateral aspect. So what is the diagnosis now?
So can you show the video again, sir?
Yeah, sure. She initially complained of paresthesia of the right shoulder and numbness of the thumb and index finger. Okay. There is no sensory loss in the thumb and index finger, but she had numbness on the upper outer aspect of the arm. There she is telling numbness. It is different. And that's the area where it becomes more. So what does it tell you?
Multiple nerves involvement.
Yeah, that means what is the likely diagnosis in this patient?
It is probably neurologic amyotrophy, sir.
Yeah, exactly. See, the point to remember is that a C5C6 radiculopathy will not produce numbness on the upper outer aspect of the arm. Why? Because that dermatome is actually supraclavicular type. So that means it is beyond the supply of the C5C6 root. Okay. So this, as you said correctly, and one of the classical site of numbness of brachial neuritis is upper aspect of the right or the right upper right arm, or sometimes coin-shaped area in the supply of the axillary nerve. So upper aspect of the nerve. So follow up after 5 days of IV methylprednisolone. In fact, the other part of video was missing. The herpes extension which was weak become normal, and the reflexes remain absent. And the other deltoid and weakness did not improve completely, but there is partial improvement. The story does not end there. On reviewing the past history, she had 2 previous episodes of brachial neuritis, one on the left, another on the right side, both improved with a short course of steroid. So this story she did not tell divulge earlier. She came with the root pain. Initially, we thought she came with a cholera and all. It was very much like, because that distribution is typical of C5C6 root or upper trunk, right? The only point against was she was no Sperling time was positive. But what made, can you tell me what is the reason why brachial plexus was suspected and did look for the numbness of the outer aspect of the arm? What is the point in any idea?
Supraspinatus, sir.
That piece affected in both. Supraspinatus will be affected in both C5C6 root and as well as in brachial neuritis.
NCS normal, sir.
NCS can be normal in both. Brachial neurology can be normal in the radiculopathy also it can be.
No root pain.
Root pain is not. Root pain is there. He's got a pain. They don't increase by coughing. That part is correct. But it's comparing a pain radiating down the arm to that thing. This is the one which I thought is unlikely because her disc was not an acute disc. This is a chronic disc. See, this disc cannot produce a weak pain and weakness of 2 weeks duration. That is the thing which made me say this cannot be due to a disc prolapse. This is a chronic one, one above and one below. So that's a point which made me think, look for the numbers in the outer aspect of the curve. Then the story came that she had involvement before. Just repeated again, this one. Okay, this is the story. Sparing the senator sandwich anyway, I could not test because being a lady, I did not want to check her back. The point was, I would be a chronic one, not an acute one. So, any questions before I go to the next?
How do you say that disc is chronic, sir?
Because it is dark, in acute disc always is hyperintense in T2. Chronic one will be just like black one.
Okay.
She presents with acute pain. In fact, she has disc prolapse on the other side also is there, chronic disc.
Yes.
One level above also is there.
Sir, is it something like a posterior cord and upper?
No, it's the upper trunk.
Sir, upper trunk. Okay, and that can explain the wrist extension as well.
Yeah, it can explain.
Right.
Yeah, right. Because this session is, as I told before, the service telling about this, it is a predominant supply is the C6 wrist extension. C7 contributes predominantly C6. Okay, shall I go to the next case? Or any more doubts in that case?
Next case, sir.
Okay. The story of a 58-year-old man. This case was referred to me by Dr. Adhakrishnan from Medical Trust. His complaint started as difficulty in elevating his left foot since 2013, that is 12 years back. He was investigated and treated with what was the treatment even earlier we did not know. The weakness remained almost the same till 3 years back. With that foot drop, he was carrying on with wearing on. 3 years back, he noticed tendency to fall while walking in the form of buckling of the knees and difficulty to get up from the floor. He also noticed numbness of the tips of the fingers of the right hand for the last 2 years. So, this is a story. For 12 years, he has been having foot drop on the left side. Then, for the last 3 years, he's noticed tendency to buckle the knee and fall, which he tells us imbalance while walking. Numbers of the tips of the fingers of the right hand for the last 2 years. This is the story. On examination, he has got upper limb, tone, power all normal. All muscles, the upper limbs were normal. Finger flexors are all normal. Flexor pollicis brevis, opponents, finger abductors, it all appeared normal. Palmar sign was negative. Palmar intrusion were also negative, normal. No finger nose incoordination. Okay. Now come to the lower limb, wasting of the left corticeps and anterolateral compartment of the thigh, which you cannot make. I don't know. You can make it. Can make out the wasting of the left thigh. Flexion of the hip was mildly weak on the right side, but more weakness on the left side. Bilaterally weak, more on the left side. Knee extension was normal on the right side, but weak on the left side. That is weak. Breast flexion normal right side, weak on the left side. Mostly weak on the left side. EHL normal on the right side, weak on the left side. Flexor pollicis longus is normal bilaterally. Evasion was normal on the right side, weak on the left side. Mildly weak on the left side. Sorry, inversion, the position. Evasion was weak on the left side, normal on the right. Plantar flexion normal bilateral. Adductors is normal. Abduction appears normal. Knee extension was weak on the left side, normal on the right side. HL was weak on the left side. That small muscles appeared normal. Come to the reflexes. Upper limb reflexes were normally elicited. Finger flexion normal. Knee jack both absent. I checked again with reinforcement, again absent on the right side, also absent on the left side. There is only a tremor which is seeing, not reflex contraction. Ankle jacks were normally elicited. Plantar indefinite. Touch sensation all normal, but his touch is normal. Pain, he was still decreased pain on the anterolateral aspect of the leg. There is decrease in the lateral aspect of the leg on the left side. There is again really little difference in the dorsum on the left foot. Other area seems normal.
Okay.
Is it normal on the thigh bilaterally? The middle aspect of the leg is normal. Lateral aspect of the thigh is also normal. Upper limb vibrations normal. He said decrease over the knee. I do not know is correct or wrong. Sometimes he's telling it is present, sometimes not present. Not very convincing. But distal part he says it's present. But definitely. Now he's telling it is present. Joint sense normal in the upper limb. Lower limb, right lower limb is normal. Left, he cannot feel at all. He decided JPC is absent. Totally wrong. Little toe also is impaired on the left side, normal on the left. This is how he walked. I got a foot drop on the left side. He can stand on toes but not on heel. Rhombus is negative. Tandem walking, he could do relatively well. Mild imbalance. He's got postural muscle weakness on the hip, mainly hip flexion and knee extension. Hip abduction was normal. So findings confined to both the lower limbs. Wasting of the left quadriceps and anterolateral compartment of the left lower limb. Tone normal. Power. Left lower limb, weakness of the left hip flexion. Knee extension. Weakness of dorsiflexion. EHL. And evasion of the foot. And hip extension, I forgot to write. Hip extension is also weak. Right lower limb, it is not normal. The hip flexion was mildly weak. Other muscles are all normal. Detail upper limb normal. Both lower limb knee checks were both absent. Both angles normal. Plantar indefinite. Sensory touch and pain. Touch is normal on the lower limb. Pain is a decreased over the left lateral leg and dorsum of the foot. Vibration, very impaired over the knee. I'm not very sure about it. But distally is telling correctly. What is definite sensory is that impaired JPS sensation in the left foot. This is undoubted because it's telling correctly on the right side. Left, he could not feel both in the toe as well as in the little toe. In big toe as well as in little toe. Curie impaired on the big toe, aortic very super. Stands normal, rhombox negative, foot drop on the left side. So you want to see the findings once again, I will tell that thing. This is the finding, wasting of the corticeps. Weakness in left hip flexion. Hip flexion also is weak. Knee extension, weakness reverse flexion, EHL, elevation at the foot. Hip abduction was normal, adduction was. So where is your localization? What do you like to do?
It appears to be a lower motor lesion, sir.
Very good.
One is a chronic old problem, and other is a superimposed new problem it has developed. The old problem appears to be a left foot drop, sir. Maybe common perineal, we don't know, sir.
Yeah, maybe.
But new one, suppose with wasting of the thigh and decreased reflexes, appears to be a lumbar plexopathy or a radicular neuropathy, sir.
Okay, very good thought. The only thing is then how to correlate both the things together. Both came on the same side.
But there is chronic 3 years deficit.
Yeah, correct. One is 12 years, other is 3 years. So do you want to consider
combine both, then again recurrent lumbar plexopathy we can consider, sir.
Okay, correct. Initially there was one plexopathy left over with sequelae, other one which has come, but he had never complained of any pain in the leg. He was never complained of that. Suspected plexopathy, neither before nor now.
So can this be a cornus cauda lesion, sir? Because the hip flexion is rather uncommon in a.
Cauda equina can, if the radiculopathy extends above, you can explain that. But what is it? It's a cornus lesion. There's no bladder, no perineal sensory loss, nothing. Angle jacks are well elicited.
But there is a sensory loss.
Yeah, sensory loss is there on the leg. You already said is correct.
L4, L5, S1 sensory loss is there.
Yeah, correct. That's there. But that can go with the neuropathy as well as radiculopathy as well.
Mononeuropathy multiplex.
Yeah, mononeurous multiplex is a good thought that can explain everything. Maybe femoral neuropathy plus conperoneal palsy, especially the hip abduction is preserved. That speaks against the pardon?
So in femoral neuropathy, we can explain the knee jerk absent and the power loss, but we cannot explain the absence of sensory loss in the medial aspect of leg. We cannot completely say femoral neuropathy.
Right. What you said is correct. But we have to find some localization. No? There are odd points for many things. For example, if you think of radiculopathy, okay, you can go for think of radiculopathy, but imagine that person has got hip extension weakness and dorsiflexion weakness, but hip abduction is spared. So that is odd for L-phase radiculopathy. If you think of a mononeuropathy, that's also feasible. Only thing is that there is no sensory loss in the femoral level distribution. Agreed. But all neuropathy need not have sensory loss in the distribution. Sometimes motor may be predominantly affected. Sensory may be predominantly sometimes. That's difficult. We have to think in a broad way. So you can think atypical radiculopathy. Yes, you can think some muscle may be spared. But we have to have some localization. One thing is certain, this seems to be element paralysis. Because good wasting and good reflexive. So element paralysis is there and sensory also. So where do we like?
Both is knee jerk is absent, sir, but ankle jerk is present, sir.
Correct. Perfectly right.
But his JP is lost over grade 2, left grade 2, sir.
Correct.
This shows some differentiation, which it's very difficult.
Yeah, very difficult. That's about the case. If it's a straightforward mononeurous multiplex or straightforward radiculopathy, will I bring the case for your discussion in this forum? So you have to think out of the box. You have to think something, some side we can explain everything in this section. Is little to numbness is there. JP is affected, but at the same time, angle jerk is preserved. It is S1 root. So it's I got point for that. Same token is also against for a neuropathy also.
What are the cremasteric reflex and the lower abdominal?
No bladder problem. Nothing. Absolutely no bladder. I did not check for chemastic. I did not look for. No other bladder problem. No perineal anesthesia. Nothing.
Abdominal reflex are all normal, sir.
No, intact. Abdominal reflex is intact.
Because to involve the hip flexion, we have to have a extensive radiculopathy or a proximal lesion.
Yeah, right.
Sir, we
Okay,
should
so
explain that also,
yeah.
sir, because the one site which can explain the absence of knee jerk with the presence of ankle jerk will be epiconus, sir. Epiconus lesion, sir.
Very
So,
good. That's
after info cord here, even though it appears to be a element paralysis, it can be a radiculo neuropathy where the lesion also lies in the cord, within the cord also, sir. That is one doubt.
yeah, right. What you said is exactly correct. But you can think everything by epiconus lesion, correct? But then where do you want to bring again radiculopathy and all? You can explain by epiconus.
Sir,
That's a good.
other routes are also involved, sir. I
Like,
cannot
for example,
explain the sir. So example, femoral L3, L4, we can explain the
epiconus lesion must have gone up, ascended up. Epiconus lesion does not mean that it's only confined to the epic. It can go up.
yes,
Lesion is inside the cord, no?
Yes, sir.
Lesion need not be restricted to the epiconus. It can go up to the L1 segment, can produce flexor weakness also. That you can argue about it.
Yes, sir.
Okay.
Thank you, sir.
Okay. Then the problem comes out to explain the S1 sensory loss and the German sense loss. That is very definite. The APC is affected in the big toe as well as in the little. Undoubted. That is L5 and S1.
Posterior column, sir.
Correct. So you got to I think we had a good discussion on the localizers. They can still explain by an epiconus by involving the posterior column. Okay. Okay, what test you want now?
SSCP, sir.
SSCP, first we think of common things first.
MRI of the cord and the lumbar areas.
Lumbar, the caudate vena, MRI and NCS also is important.
Yes.
You want to look at monoid multiplex is another possibility which cannot rule out totally. So left L5 to S1 radical in the left side by S1 because the JP is affected, but many points are against. So probable radical in the right side also. What is one possibility is a caudate vena or a monoid. This is the thing which straight away once comes to your mind. So what test you need? The NCS was done, in fact, 1 month prior to the present and we shall show the NCS first. This is the NCS finding. Decreased CMAP amplitude from the tibialis anterior, left femoral, and upper limb normal. Except for he has got a CTS on the right. That is why he's got a numbness in the tips of the fingers. So that seems to be totally unrelated because he's got a carpal tunnel syndrome. Left gastroc tibial was normal. F5's left peroneal was absent, obviously because his amplitude was very low, 2.2. That is the reason probably he has got absent this thing. F5. Sensations all normal. Sural, supratal peroneal, all normal. Okay, this was the initial conduction. H reflex also normal. No. What do you want now?
Repeat the NCS.
Pardon?
This is 1 month prior to current.
This is, the repeat NCS first, and I'll show the repeat NCS. But not 3 weeks, but the illness has been there for long. So even 1 month back NCS also is good enough. The story is a long one, 3 years back. But anyway, I repeated the NCS, I will show that. Before the MR, LS spine was done. This is LS spine. Yes, mild listhesis between L5 and S1. There is a T2. This axial cut. No significant stenosis anywhere. This is the T1 sag. T1 axial. This is a space sequence. Space is taken to find out any vessel abnormality or dural or something like that. You can take the space sequence. There's also an abnormal vessel channels one you have seen. This is screenshot. This is that T2 sag. This is L1, L2, 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 3, L3, L3, L4, and L4, L4, L5, 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 S1. So what else you need now?
So NCS of femoral was normal, sir.
Femoral was decreased, EMF amplitude decreased. The previous one. So also the repeat one. This is a repeat one. This is a conperoneal decreased amplitude. In fact, compared to the previous one, the amplitude is little better now. It is 4.4 now. The previous one I'll show you. Just I'll show the previous one. 2.2. Okay. So in fact, it is little better now. Sorry, it was from the EDP. EDP is a little, no, it was, no, what is it? It is still worse than before. Initially it was normal, it has come down now from the EDP. From the TA, it is same. Then femoral non-potential picked up. Initially it was little small amplitude it is absent now. Sensory, same. That is evidence of CTS on the right side. Otherwise, lower limb sensory potentials are not. Okay. That's carpal forget about it. HRF is also not. Now, with this electrophysiology, what is your localization? How does the electrophysiology help you?
So axonopathy, sir. Axonopathy.
Yeah, very good. It's the axon involvement, correct? Then where is the likely site of the axon involvement? Next thing. It's in the peripheral nerves, it's in the roots or?
In the roots, sir. Roots.
Okay, root. Okay, radiculopathy is one possibility.
Or it can be anti-horn cell also. Anti-horn cell also.
Yeah, anti-horn cell also. So which do you prefer in this patient, anti-horn cell or root?
Anti-horn cells.
Because he's got H reflex is preserved. You have a sensory loss in that area. That means S1 root is not responsible for the sensory loss. Okay, we have to find some other explanation for the sensory loss. So keep it there. So what else you need?
Needle EMG, sir.
Okay, needle EMG is going to help us anyway. The point you have to remember is how you have to go step by step. So we thought it's a monoid multiplex one possibility. That's straight away out because NCS is not favoring that thing. because sensory potential is normally in the nerve where in the area where the sensations are affected. So that point is out.
Sir, but femoral is absent, no, sir?
Yeah, but that can be absent due to, as Umar was telling, due to at least anywhere, maybe in the anterior horn cell, the area, or maybe in the root, or in the nerve. Let's take it to be nerve because there is no sensory loss in that area. Okay, so this shows that it's not a nerve. Still could be a radiculopathy. Yes, it can go with the radiculopathy. The only odd point is the the sensory loss, the area where the S1 root sensory loss is there, H is preserved. That is still odd. Otherwise, it can be very well by radiculopathy. Nothing against radiculopathy. CMAP can decrease anywhere from anterior horn cell down. But sensory potential preserved means at least has to be proximal to the ganglion. Okay. Now, what will you like to do?
The proximal stimulation.
MRI of the dorsal cord, sir.
Okay, MRI of the dorsal spine. So let us see the MRI of the dorsal spine. Because I forgot the name on that lady doctor. She correctly said epiconus. If you want to learn epiconus lesion, it's a good possibility you have to keep in mind. Let us see if there is anything in the epiconus. Sagittal cut. This is axial.
Is there any vertebral lesion, sir?
No, you see, look at the hyperdensity. Vertebral lesion is not there. See the hyperdensity within the cord there. Little more down, you can still make out the hyperdensity, also, and mainly on the left side. And epiconus region is markedly hyperintense. Not conus, epiconus region. I'll show the screenshot later on. There is a vertebral lesion. I mean, there is some projection of the vertebrae is there. That may, I mean to say the osteophytic protrusion is there, as well as some other finding. The protrusion from behind. See that one. That is from behind. And you can see the hyperdensity there. I'll show the screenshot. Okay, that's hyperdensity. You can make out the hyperdensity here at the level of D10 and D11, exactly corresponding to the epiconus. That is the constriction there. Now, this is the area. You can make out the hyperdensity there. But there is no real compression from the disc. Okay. Again, you can do hyperdensity in the epiconus, mainly in the posterior part. And on the side of the compression, I mean on the side, on the left side, there is some protrusion from behind the most likely calcific of the ligament flava protruding anteriorly and in disc anteriorly. Again, that is kinking the lateral part of the canal, not on the central part. This is hyperdensity within the epiconus, mainly on the left side. And this is the epiconus part showing the hyperdensity, mainly posteriorly situated. And this is a calcified ligament flavum and epiphyseal joint protruding inside. But that's not causing complete canal stenosis. Only on the left side it is compromising it. But the hyperdensity is seen much above the level of the calcified ligament flavum. So what is the diagnosis now?
So any possibility?
Please, yeah, possibility of? Your sound went off in between. Can you repeat, please? Hello?
Fibrocartilaginous embolization.
Possible, there's embolism is possible, but it's not presentation like a fibrocartilage embolism. This is 20 years back, gradually progressive, then static, then this is also developing, not an acute presentation like this. Pericardial embolism is acute, often preceded by some trivial physical labor and preceded by pain and all. And you
Will
can
a
see some,
contrast,
pardon?
will a contrast study helps?
Contrast will not help because you already see some compression of the osteophytic calcified lesion protruding into the canals on the left side. But you can find a hyperintensity in the cord above that also. I'll go to the previous one. That is hyperintensity is extended to 3 segments above. See, that is the area of hyperintensity. At that level, there is not much of a compression. Compression is lower down.
And that
So
is
there is
possible.
definite hyperintensity inside the cord.
Correct, exactly.
So though that this hyperintensity is related to any problem with the vascular supply.
Exactly, that's a correct thing. Okay, so even though there is a lesion, constrict lesion below that, but hyperintensity is above that. Okay, so that means hyperintensity is not due to the direct compression at all. If it had been compression at that level, there is no compression. You see that cord there. And if you go to the axial cut also, the axial cut also, see there's hyperintensity, anterior posteriorly nothing. Here also hyperintensity, no compression. Here also hyperintensity is there, but no much compression. But what is projected seen is there only. So what could have been the responsible for that? Yeah, this is an ischemic myelopathy. The question is why the ischemia occurred above the site of compression?
Venous drainage.
Okay, venous drainage is possible, right? Okay, this is well-known corners. Before that, I'll tell you some brief about the anatomy of the blood supply of the corners region. The ischemic myelopathy diagnosis is called a dorsal watershed zone infarct. I'll tell you what is this. This is exactly the dorsal. See, the question is dorsal. Keep that picture in mind. Subsequently, I'll be showing the other pictures also. Okay, now come tell me a little bit about the anatomy of the blood supply of the spinal cord. As you know, this is supplied by the antispinal artery. It is replenished at various levels. And one of the main replenisher is the Adam-Kiewicz artery, which is seen here. I hope you are able to see my arrow, which divides into upper division and lower division. Lower division comes downward and supply the epicornus, cornus, etc. like that. And this is replenished by another artery from the lumbar artery, which go and replenish the subsequent antispinal artery. But what is interesting is that if you look at the lowermost part, this antispinal artery is going backward. Okay, I'll show the next film, next picture. This antispinal artery, Adam-Kiewicz. Now let us see this one. At the junction between the two adjacent sources of the blood supply, I think I explained it. That is artery for Adam-Kiewicz, the largest anterior segmental artery, is responsible for the perfusion of the sizable region of the spinal cord as it supplies the caudal 2/3 of the antispinal artery. The artery of Adam-Kiewicz originates from the left posterior intercostal artery, a branch of thoracic artery aorta at level T9 to L1. It always enters through the left side of the canal. Immediately following its point of origin, this extends through the intervertebral foramina of the corresponding spinal level. It then ascends on the anterior spinal cord as many as 2 or 3 vertebrae before it undergoes a characteristic hairpin curve, after which it immediately anastomoses with the antispinal artery. That is what is shown here. There are 2 watershed zones. One is longitudinal watershed zone, other is horizontal watershed zone. At the junction between the 2 adjacent sources of the spinal blood supply, that is a cervical branch of clave in origin, cranially, and the intersegmental arteries of the aortic origin caudally. The horizontal watershed zone is inside the spinal cord, intrinsic spinal arterial system, and the higher metabolic demand of the granulomatory determines the variable patterns of isolated granulomatory ischemia, ranging from classical snake eye appearance to whole granulomatory infarction with a spared wide. Now, this is the one which I want you to remember. This is called periconal anastomotic circle. Tell you something about that. The antispinal is coming down. Near the caudal extremity of the spinal cord, the antispinal artery gives two small lateral branches that curve sharply backward and supply the dorsal surface of the cornus medullaris and continue cranialward as the lowest portion of the left and right posterior spinal artery. So putting in simple terms, you know the antispinal artery coming from front, two posterior spinal arteries coming from behind. The lower part of spinal cord, this antispinal artery gives two branches which curve around the spinal cord and replenishes the posterior spinal artery. So their flow is now retrograde. It is going upward from below. Posterior spinal artery as comes down, becomes thin and thin, it loses its blood flow. That is replenished by a curved one which is going upward. And this is what is shown here. Look at the right picture, this antispinal artery. This is the one artery coming to the final term. It curves around and replenishes the posterior spinal artery. This is the artery going backward. Again, this picture shows a little more clearly. What is the anterior one? This is antispinal artery here in the front. It curves backward on both sides. From here, it is coming like that. It's coming like that. And this is the posterior spinal artery here. So what will happen? The cranialward posterior spinal artery is supplying from below, above downward, and below the posterior spinal artery, which is replenished by the antispinal artery, is going upward. And this is a watershed area. That is called the dorsal watershed zone. So it characteristically occurs in the dorsal part of the spinal cord. That is the watershed between the descending posterior spinal artery and the ascending posterior spinal artery, where the retrograde flow in the posterior spinal artery. So the dorsal watershed zone of spinal cord. This illustration depicts the circulation patterns with the spinal arteries at the level of the cornus medullaris. Note the anterior to posterior flow in the arcuate branches, the ascending flow within the lowermost part of the posterolateral and posteromedial spinal arteries. This is called the posterolateral spinal arteries. That is part of the posterior spinal artery which is replenished by that. This is a flow going upward, this flow coming downward, and that is the watershed. The dorsal watershed zone, the shaded area, corresponds to the portion of the posterior spinal network located at the junction between the ascending and descending flow patterns. Now, this is from the literature. See the pattern here. This antispinal artery curves behind and goes upward, and from above down it's downward. This is upward. This is the area of the watershed zone, and even the compression is here, involvement is here, blockage is here. The infarct is above, because the blood flow is retrograde in the lowermost part of the cornus epicornus region. And you can see this is from the literature, the classical site of the infarct in the dorsal watershed zone, just like our patient's picture. This is a focal area abnormal around the posterior superior and dorsal aspect of the cornus medullaris. Okay, that's the story. Again, this is the picture again. And this artery is called the cornal artery or Desprogus Quaterron artery, the one which goes, replenishes the supplying the antispinal artery anterior from the internal iliac artery. But more important is this one, the antispinal artery curving around and supply the cornus. Now you can explain everything, no? Why the compression below has resulted in ischemia above, and why it has become in the posterior part dorsal aspect of the cord is affected. It can also involve the antispinal, it can also involve the anterior corner, also it can produce. So any questions?
So, sir, in this case, there was some problem in the epiconus region due to the backward, the curving of the anterior spinal artery.
Correct, because antispinal is coming down and replenishing the
going
posterior
up.
spinal. Exactly. So a lesion compression below can result in ischemia above. Same thing can also occur in the compression and the Adam cubics. That is why you can have a lesion, say for example, D7 lesion can produce a level of lesion at D4. Because Adam cubics after entering divides into upper portion and lower portion. See, for example, if this is the Adam cubics. So if there is a compression here, the ischemia may be here. This may be the watershed zone from below and upward. So even the compression here, the affected area may be much above. The cord level may be above the site of actual compression. Here again, the T bifurcation here. If it is affected, ischemia is going to be above that. Okay, any questions?
Sir, should we suspect AV malformation, sir?
Not necessarily, because there are no abnormal vascular channels which could be seen here in this patient. That is why I took a space sequence. Space sequence is essentially just like a cis sequence in the brain to find out the high T2 weight so that you can clear the Cs of, it can be projected, abnormality in the place can be made prominently. Universal abnormality can be made prominent.
So why was there a 12-year gap and the 3-year gap, sir?
That I don't know what I got to explain that I do not know. But probably the reason one might have been due to the ischemia which has occurred now. The compression might have been there earlier causing this foot drop or something like that. That must have produced some radicular involvement in it. I don't know. That's difficult to explain why the gap between the two. This is a story. Or the vascular compromise have become worse.
If we had presented acutely, can we suspect demyelination in such cases, sir?
Yeah, if you don't seen but demyelination problem is he's got a predominantly element finding here. Probably maybe the antidepressants. So not the white matter lesion.
How did you treat, sir?
No, this patient, the problem is we can further that particular compression has to be removed. That's I'm planning to do that. Rest of things, nothing can be done. Ischemia part cannot be treated. You can give antiplatelet, things like that, but very difficult. It's a chronic one.
So the old foot drop is unrelated, no, sir? Or it's related to the ischemia, sir?
No, we do not know either whether the anticondylar disease is part of the ischemia, because it can be explained with the epicondylus lesion. If it is so difficult, it's not going to improve.
Because he has L5 and sensory is there, no, sir? That can be due to the old L5 and radiculopathy due to disc, no, sir? Retrolysis is
No, that's little odd. That's here again. That is why I brought it stepwise. See, if it was a radiculopathy causing the sensory loss in the foot, and then H reflex should have been absent. So that tells you that the sensory loss is not due to the root involvement, not due to the nerve involvement. It has to be due to the posterior column involvement. That is got significant loss of posterior column in the big toe as the little toe. That is undoubted. He said he cannot say anything. He does not know. That is because of the involvement of the posterior column by the watershed infarct, which is seen here. This one. That is exactly the posterior column.
So why the patient has come now, sir, after 3 years? Is it progressing or?
It is progress. Yeah, because initially he had a foot drop, remained static. Now he's developed started buckling of the knee. That is why it's come down.
But the ischemic lesion progress, sir, they remain static or improve, no, sir?
In between it was static. For 12 years he was remaining like that. Not 12, but 10 years also he was remaining like that. Then for the 3 years he started worsening. When buckling has occurred.
So could it be any space occupying lesion? We don't know, sir.
No, there's no evidence space occupation anywhere, in the MRI or anything.
No, the intrahyperglycemic can it be a small tumor or a slow growing?
No, there's no, if you look at the least lesion, there is no mass effect here. Even long durations, only confined a small area without any mass effect.
Sir, can a posterior spinal artery lesion produce similar picture?
Yeah, same exactly. It can produce same picture. It will produce that thing. If it is supposed that cervical cord and the posterior spinal artery can be exactly the same picture. In fact, I had collected various pictures of arterial supply, which I did not show purposefully. In the interest of time, I'll just, since you've asked that question, I will show that things. Just 1 minute. Okay, I'll show the various patterns. See, we have all been taught that antispinal artery should produce anterolateral syndrome, posterior spinal artery produce only posterior. It's not correct. The patterns can be very, very variable in ischemia of the spinal cord. I'll show some of the pictures here, which you can. Just 1 minute. Okay. Can you see my slide?
Yes.
Okay. So, this is one pattern, the antispinal artery infarct. It can produce bilateral motor and spinal thalamic tract as the usual pattern here. But the list may be limited to the anterior horn only, or the surrounding white matter, or extend to the posterior horn as well. It can produce antispinal artery can extend. Then this is another pattern. This is a bit the MRI picture showing the same thing. The lesion can extend somewhere to the posterior horn, also produce antispinal artery. These are all documented cases. Then anterior unilateral infarct, hemiparesis with contractile spinal thalamic, just like hemicord syndrome, sparing the posterior column due to the sulcoconvolutional artery. The patient first displayed antispinal artery syndrome with respiratory failure, which evolved into unilateral syndrome with the normal breathing. So this is from the literature only. Then, in addition to the left side lesion, there can be small anterolateral infarct on the right side of the spinal cord as well. That is also another pattern. See, it does not fit with the strict arterial territory. In the case of the posterior spinal artery infarct, the lesion may be limited to the posterior column and or extended into the anterolateral portion also. Can also involve the pyramidal tract posterior spinal artery. This is confined to the posterior column. This is confined to the anterolateral part of the cord. This is all because the area of supply of each artery is complementary to the other. Suppose antispinal artery is weak, the posterior spinal artery will take a dominant role. It supplies a lateral column as well. This is a posterior one-sided infarct. Then it can extend onto the lateral part like this. The dense one is a Paka infarct. The lighter gray is the other extended into the lateral column. This again documented infarct, documented posterior spinal artery infarct. Then they can have a U-shaped central infarct, lesion confined to the border of the anterior sulcus only. There is a central pattern. This is a central pattern. So these are the. So various patterns can occur in anterior posterior spinal artery. Need not necessarily be like a textbook description, confined to the posterior column or anterior two-thirds of the spinal cord. Okay. Shall we stop or go for one more case?
Sir, what sequence of MRI would be the best to choose for these types of ischemia? Which sequence of MRI would be the best for finding out there is a relative paucity of blood supply in the particular area?
I don't know much about that. The one which usually ask for is the T2 and T2 space. These are the two things which usually ask for. Find out the vessel abnormality and the spinal cord.
No role of any angio, sir?
MR angio, I don't know how far it is useful in spinal cord disease. I do not know.
Sir, in the acute setting, diffusion sequences will show the importance.
Yeah. That can infarct and all diffusion sequence can be shown. Always keep in mind that diffusion sequence spinal cord is not it's not foolproof. Sometimes you may not be seeing deficiency in the spinal cord at all. If it is there, it's well and
But
good.
ischemia will not be seen.
No,
Diagnosis of ischemia will be difficult.
that's not because of that. Because the resolution of that diffusion sequence was such a small area of the spinal cord will be difficult. Spinal cord is a small area, no? So it will be difficult for the resolution of the diffusion to be seen. Because the technical problem, not because of that, it's not because of the fact that infarct cannot be picked up. The area is very small, so that is the area. That's a problem in detecting in the diffusion sequence in spinal cord infarct. Okay, shall we close or go for one more case? What do you think?
One short case, sir.
Short case. Okay, I will take a short case. This case I will skip. That's a long case. No, this is a short case. I will show. 30-year-old man with progressive ataxia and progressive cognitive decline for 6 to 7 years. It's a short case. On examination, ML functions get impaired recent episodic memory and semantic memory, defective calculation and executive function, language normal, and rest of the exam impaired vibration postural sensation on the distal aspect of both upper and lower limb. Rhombus test was severely positive. So he's got a high malformation problem as well as evidence of peripheral neuropathy. He has also got ataxia, maybe sensory ataxia. I think this high malformation examination part I will skip because in Malayalam, so he's got impaired memory and high malfunction. Then second thing, second part of the examiner show, he has got evidence of absent vibration in the distal part. JP sensation. Lower limb it's impaired. This is the gait of the patient, is wide-based ataxic gait. So what is the diagnosis in this patient? It's got a cognitive impairment, evidence of peripheral neuropathy.
Deficiency, sir.
Cerebro
Exactly.
Cerebrotendinous xanthoma, sir.
Exactly. You can see the xanthoma there.
Xanthomas are there, sir.
That's the
Xanthomatosis.
Exactly. Okay,
Or
I did
is
not
there
tell
an issue of scissor? Is there an issue of scissor? Cataract?
Yeah, in fact, if he had cataract, his seizure was not there. So what did you find in the MRI in this patient?
MCP hyperintensity, sir.
Let's say we can produce, but mainly it's in cerebellar hemisphere hyperintensity in the dentate area. That you can see there. I will show this is an old picture. You can find that this is the MRI. Hyperintensity in the dentate and the cerebellar white matter. This is the clue. Tendon xanthoma. Huge tendon xanthoma.
Cerebrotendinous xanthoma.
Correct. This is xanthomas. I think I'll skip the description at all. This is a textbook picture of this xanthoma. Hyperintensity T2 in the dentate nucleus and the white matter of the cerebellar hemisphere. Then you can have the signal increase in the spinal, corticospinal tract, and periventricular white matter in the prior sequence. So it's fine glass. Fine glass appearance is not specific. Many conditions can produce that. Not only Krabbe's disease, many things, and motor neuron disease, many things can produce. Again, showing the Pons patchy hyperintensity in both dentate nuclei and surrounding deep cerebellar white. That is a classical, and you can have periventricular hyperintensity also. So that's a short case.
Sir, ursodeoxycholic acid is not available and we give chinodeoxycholic acid. Does it work?
No, I have not tried anything. I have seen only this is only 2 cases I have seen. And at that age, I don't know whether it's available also in the market.
ursodeoxycholic acid is not available. Chenodeoxycholic is available. So I had given that. I don't know whether it worked. Patient never came back.
Correct.
Chenodeoxycholic acid can be tried in high dose, sir.
Yeah, it can be tried. That's a treatment which is offered. But this patient also did not try because he could not afford anything.
Is vitiligo an association, sir?
Any?
He had
Pardon?
vitiligo. He had a lot of vitiligo.
Vitiligo, I don't know. I don't know. Okay. Shall we stop?
Thank you, sir.
Yes,
Thank
sir.
you.
Thank you, sir. Thank you,
Thanks, sir.
sir.
Good night, sir.
Thank
Thank
you.
you, sir.
Good night, sir.
Thank you.
Thank
We'll
you,
see you
sir.
next
Thank you,
week.
sir. Good night.
Thank you, sir.
Thank you. Thank you. We'll see you
Thank you,
next week.
sir.
Thank you, Bindu. Thank you.